So good evening, everyone. Thanks a lot for inviting me for a talk on the new therapy in migraine. Today is my honor, and I used to work in chronic pain center too. It's make me feel like I'm come back home again this time. Can you next slide, please? So for my disclosure, I received a small honorarium from the Alberta College of Physicians for this presentation. So for outline today, we will talk a little bit about role of calcitonin gene-related peptides in migraine, and also look into the study in the efficacy and safety of CGRP monoclonal antibodies. And we'll touch slightly at the upcoming new migraine therapy that might be available sometime this year. So for CGRP monoclonal antibodies is open the new world for headache medicines because it's the first group of medication that designed specifically for the treatment of migraine based on migraine pathophysiology. And since 2018, we have 4 CGRP monoclonal antibody available in the market. So CGRP molecule itself is abundant in trigeminal cervical complex and involves in a lot of pain pathology, particularly in the headache, but it's not just in the pain system, but it involves in other organs of our body as well. For example, when you look at cardiovascular system, it has protective vasodilatation as it prevents people from develop hypertension. In pregnancy, it controls the uteroplacental blood flow and also uterine relaxation, and also prevent gestational hypertension. And another one that I would like to emphasize today is gastrointestinal system, that it involved in the motility of intestine. By blocking CGRP molecule can lead to some of the side effects affect these organs as well, which I will mention after this. So nowadays we have 4 that are available in the market, but in Canada we only have irinumab, galcanezumab, and fremanezumab. So CGRP monoclonal antibodies are engineered to be highly target specific and also have minimal off-site targeting. So as a result, it have less drug-drug interaction compared to a standard medication that we used for migraine before. It also have less systemic side effects. Also, with the large molecule of monoclonal antibody, it doesn't cross blood-brain barrier. So it have fewer CNS side effects of somnolence or dizziness. It also have long half-life. When you look at the table, it lasts up to 30 days at a time. So it makes it more convenient for the patient to use. So in these 4, irinumab have slightly different mechanism. It binds to the receptor of CGRP, but the rest of monoclonal antibody will bind to the ligand. And epinezumab is the only one that administered by IV infusion compared to the rest of 3 that you can give like an auto injector for the patient to use at home to apply either monthly or quarterly, depend on the formulation. Also, in the patient who have hepatic or renal dysfunction, CGRP monoclonal antibody also considered safe to use in this population, as it doesn't require hepatic or renal clearance at all. On the other hand, it's break down by the reticuloendothelial cell locally wherever they're extravasated out of the blood vessel. So there's a number of study already that show efficacy of monoclonal antibody in migraine, both episodic and chronic. But what I would like to emphasize from these slides is there's 2 populations that sometimes it's difficult to treat, like patient who has failed up to 4 preventive medication we consider as a medically refractory patient, and also up to 40% of the patient that recruit in the study of chronic migraine have medication overuse headache. Monoclonal antibody also show benefit in these 2 populations in terms of reducing the monthly migraine day, reducing the use of medication per month, and also improve headache-related disability as well. For the side effects of medication, either in clinical trial or post-marketing report, they are in line. So the common one is injection site reaction, injection site pain and rash. Also, irinumab have potential to cause constipation. Other side effect is increased risk of nasopharyngitis and upper respiratory tract infection. Post-marketing report, they show that there's very rare cases of anaphylaxis or angioedema. In the study, they show one cases in the trial of epinizumab, and post-marketing show cases in galcanezumab. Also, FDA and European Medical Agency had issued the statement warning of using CGRP monoclonal antibody in particular patient, those who have long-standing uncontrolled hypertension or long-standing constipation, because there are a few cases that need to be hospitalized to treat their symptoms after they receive doses of CGRP monoclonal antibody. And also because it had been in the market for at least 5 years, and long-term study also available, and also it showed consistent benefit throughout the period of the study between 1 to 5 years, depending on the medication. The side effect, although not much different from the earlier trial, and dropout rate or discontinuation rate is quite low, about 3 to 5%. Also, one thing that they try to look into is whether this medication is safe for patients with cardiovascular condition. Throughout the study, there's no report significant cardiovascular event. And also when they monitor ECG and blood pressure, there's not much different from the placebo group. In general, it's supposed to be safe, but with the physiology that involved in the protective vasodilatation, we're still not sure whether it is really safe to use in those populations. And one thing that has been a problem for a long time with the patient who use the standard of care oral preventive medication is the adherence. Earlier US studies showed that only 13% of migraine patients still stay on preventive medication after a year, but recent study that come out look at the pattern of the patient who use CGRP monoclonal antibody. It show higher persistent rate, higher adherence, and also fewer patients who discontinue from medication compared to those who take standard oral preventive medication. And most of migraine patients are women of childbearing age. The question also come up, can I use this medication during pregnancy? So WHO pharmacovigilance database has recruited over 20,000 of pregnant women who exposed to various medication, but not many patients that exposed to monoclonal antibody, only about 94 reports that exposed to one of these, and most of them occur during pregnancy. When they analyzed the data, didn't show any specific maternal toxicity related to it, and also no major birth defect or spontaneous abortion, even though it seemed like it relatively safe to use during pregnancy, but with the limited number of the report, they still don't recommend using monoclonal antibody during pregnancy yet until we receive more long-term safety data related to this medication. It seemed like when you look through this, it seemed like CGRP monoclonal antibody has many advantages over oral preventive medication. It had high target specificity, has less side effects, high adherence, and more convenient. Also, when you look at onset of action, in IV infusion formulation, in the study, you can see reduction of the headache as quickly as the first day after infusion. But for the formulation in the subcutaneous is less than a week that you can see benefit compared to oral preventive medication that can take up to 3 months to see full benefit of medication. But keep in mind that there's no real head-to-head trial to compare the efficacy of CGRP monoclonal antibody and standard of care of the older oral preventive. So we cannot say that CGRP is better, but if you look at the profile, it seems like it's more enticing to use, or the patient might be interested in CGRP monoclonal antibody more than the standard of care. So in conclusion, this is a new era for migraine treatment, as CGRP monoclonal antibody has shown efficacy and safety in clinical trial and have better tolerability and adverse and adherence. But in some population, those with hypertension and consideration, we have to be very careful to use this. And so far, we don't recommend to use in cardiovascular patient or pregnant patient yet. Upcoming therapy might be safe though in those who have cardiovascular or cerebrovascular disease. And if you want to look into like something summarized in clinical practice, American Headache Society has launched the consensus statement last year. It summarized the new medication that I mentioned today, but it's not as much in detail, but it will be good resources for you when you want to look up for that. And this is at the end of my slide. I'm happy to take the questions.
Thanks so much, Prin, and that was like perfect timing. So we have a few minutes for some questions from the audience. So anyone who wants to give a question, please either raise your hand or Kathy will read out the questions from our chat log.
And so I do have a question here in the chat log, and Nash asks, hi, thank you for your presentation. In your experience, is there a rebound migraine upon discontinuation of CGRP?
So there's a study from Switzerland, I think from last year, that they tried to discontinue the medication after a year. And the study showed that you can see the rebound of the headache after a month, and after 3 months it's very close to their baseline. That's the only data that I have at this moment.
Okay, that's great. I actually have a question. How much do these cost, and does uninsured health benefits cover it?
Yes, so it's about $800 per dose. So monthly it's going to cost about $800, but there's a patient assisted program for each company that they reduce about 20%. So it still costs a little bit over $500. Some of one of these three, the drug representative that they already in the basic plan of almost insurance, which is fremanizumab, and galcanezumab is try to push through many insurance as well, and hopefully we can get through it easier. But I heard that now the insurance or Alberta Health try to make it a little bit more difficult, limited the prescription to just neurologists, which is, I don't think it makes sense. It should be everyone who know how to use it. That we try to work with the Alberta Health Service and insurance at this moment.
Would you happen to know if it's covered for non-insured health benefits? So that would be for the Indigenous population?
So that one, normally you still have to fill the special authorized form.
Special law? Okay.
Yes, they still have to look into that. But a lot of insurance is in the basic plan. Normally they will approve, but there's a criteria that you have to fill at least 3 other preventative medications first, and you are not allowed to use in conjunction with Botox.
Okay, good to know. And I have a final question. So I wondered about drug coverage, but I also, you mentioned it helped with medication overuse. Does it help with traumatic or like post-concussive migraine?
So the data still not there, but fremanizumab, one of those, have been studied in post-traumatic headache, but unfortunately it showed negative outcome.
Oh, okay.
Yeah, but we still use if the patient have clear history of migraine before, or have the characteristic of migraine after the post-traumatic headache, that might be because of trauma triggered the migraine. It still might benefit the patients.
Oh, great. Thank you. Any other questions? Anyone monitoring? There's Lori.
Sorry, I have a possibly annoying question. Prin, I have not been able to get anybody to explain to me why Blue Cross decided to cover fremanezumab and not the others.
Yes, I think it's about the drug company, because when I heard this from drug companies, so that they try to deal with Alberta Blue Cross. Yeah, but in
So
fact,
they just lobbied better.
yes, and Emgality actually is in Alberta Blue Cross too, but with group coverage, but not in the non-group coverage yet.
Yeah. Okay.
It's about lobbying, I
Yes.
think.
I also find it annoying that they will not let me prescribe praminezumab, but
Yeah.
that's a problem for another day. No, I just wondered whether, you know, the data, as I see it, is pretty equivalent. Maybe side effect profile might be slightly different, but yeah, I just wondered if I was missing some reason why it's dramatically better.
No, not at all. They are the same.
Any thoughts from our pharmacy colleagues out there?
It's the same questions and frustrations that Lori voiced. We have asked some drug reps as well too, but as you know, we do have at the Chronic Pain Center the headache department as well, and our two doctors are struggling to even continue to write the Jovi or other CGRP antibody prescriptions, and it is an ongoing frustration, and there seems to be no real answer nor easy fixes to it. I just typed in that if you have a patient, like Veterans Affairs will also cover that as a special auth, but again, special auth. And I do not believe that Veterans Affairs requires to be a neurologist.
Yeah, it's just recently, I think it's just from some of the insurance that they will require from neurologists only, which we try to work on that, because I don't think it's reasonable to do so. Yeah.
However, if you guys have any workers' comp patients out there, workers' comp patient caseworkers have been pretty lenient for the coverage, just in case.
Okay, well, if we have no more questions, I think we can call that a wrap. A very successful presentation. Thank you, Prin. That was really interesting, and I especially appreciate the you know, kind of frustrations of our health systems issues and talking about that too. So thank you so much, and yeah, please stick around if you can, and because we'd love to have your insights.